What is the history behind bladder cancer type classification? Imagine trying to understand a complex puzzle that keeps changing as new pieces are discovered. That's how the classification of bladder cancer has evolved over many decades. It all started with simple observations under the microscope, where doctors looked at the shape and appearance of the cancer cells to figure out what type they were dealing with. Since most bladder cancers come from the lining of the bladder, called the urothelium or transitional cells, early classifications focused on identifying tumors that originated there. These are called urothelial or transitional cell carcinomas. Less common types, like squamous cell carcinomas, adenocarcinomas, small cell carcinomas, and sarcomas, were recognized based on their distinct cellular features and origins. This basic classification remains important today because it helps guide diagnosis and treatment. As doctors learned more, they realized that not all tumors are the same in how aggressive they are or how they might behave. So, they developed tumor grading systems to describe how much the cancer cells differ from normal cells. In the early 1970s, the World Health Organization introduced a 3-tier system, dividing tumors into Grade 1, Grade 2, and Grade 3, based on how well differentiated or poorly differentiated the cells appeared. But this system had limitations, especially in predicting outcomes for early invasive tumors. To improve this, in 2004, the WHO and the International Society of Urological Pathology simplified the grading into just 2 categories: low-grade and high-grade. This made it easier for doctors to predict how the tumor might behave and decide on the best treatment options. Alongside grading, staging became a key part of classifying bladder cancer. Staging describes how deeply the tumor has invaded the bladder and whether it has spread to lymph nodes or other parts of the body. This was standardized with the TNM system, which stands for tumor, node, and metastasis. Developed in the late 1960s, the TNM system helps doctors determine whether the cancer is confined to the inner layers of the bladder, called non-muscle invasive bladder cancer, or if it has grown into the muscle layer, known as muscle-invasive bladder cancer. This distinction is crucial because muscle-invasive tumors tend to be more aggressive and have a higher risk of spreading, requiring different treatment approaches. In recent years, advances in molecular biology have opened a new chapter in bladder cancer classification. Researchers started analyzing the genetic makeup of tumors, looking at gene expression patterns and mutations. A landmark study from the University of London in 2012 identified 5 molecular subtypes based on gene activity: urobacil A, genomically unstable, urobacil B, squamous cell carcinoma-like, and infiltrated. These subtypes differ in how they grow, respond to treatments, and their likelihood of recurrence. For example, some subtypes show mutations in genes like FGFR3, PIK3CA, and TP53, which can influence prognosis and therapy choices. This molecular approach aims to personalize treatment, moving beyond just how the tumor looks under the microscope. In summary, the history of bladder cancer classification is a story of progress from simple cell-based observations to complex genetic profiles. Today, doctors consider the cell type, tumor grade, stage, and molecular features to better understand each individual case. This integrated approach helps improve diagnosis, predict outcomes, and tailor treatments to each patient's unique tumor. For anyone facing bladder cancer, understanding this evolving classification system underscores the importance of personalized care and ongoing research. Always consult healthcare professionals for advice tailored to your specific situation, as each case is different and requires expert guidance.